Hi everyone, welcome to this recording. It's a really important day today. This is part of World Polio Day, and we really want to celebrate the work that is being done by the British Polio Fellowship. My name's Ruth Stross. I'm head of nursing with Neurology Academy. I have a background as a neurology specialist nurse, and I'm joined here today by some really key people who are part of the work that is happening with the BPF. And we just want to talk to you about some really exciting recent work that has just been published. Let me hand over to Kripen.
My name is Kripen Dhrona, and I have the honour to be the Chief Exec Officer at the British Polio Fellowship.
Excellent, thanks, Kripen. Francis.
Hello, I'm Francis Quinn. I'm a trustee of the British Polio Fellowship, but I'm also a polio survivor. I contracted polio in the UK in 1957.
Thank you very much. And the other person who will be joining us is Dr. Simon Shaw.
Hi there, I'm Dr. Simon Shaw, and I'm the clinical director of the National Spinal Injury Centre at Stoke Mandeville Hospital.
He has also been a really key part of the work that has been done by the BPF. So I guess welcome. What I think would be really key for us to understand, I have background in neurology. I think a lot of people that will be watching this and listening will be kind of wanting to know a little bit around the background to the British Polio Fellowship. Where did it come from? Where was the need identified, and what was the support that was originally felt to be helpful? I don't know. Shall I hand that one to you, Kripen?
The British Polio Fellowship was set up by Patricia Carey and Frederick Morena in 1939, shortly before the Second World War started. And it was one of the first charities in the UK to be set up by a patient cohort to support their own needs. And in that respect, it was a groundbreaking charity because it's recognised that polio survivors had a very unique need. And this wasn't being met by the charitable services available at the time. It was mainly set up to support young children, but really anybody affected by polio, but primarily young children, manage the virus and live and the treatment they would get for the virus, and how to manage their lives after the initial treatment. As time developed, it continued to support polio survivors in different ways. And over the fellowship's 85-year history, the charity has continued to adapt and change to continue to meet the needs of polio survivors as their needs have changed as they get older.
Thanks, Kripen. And I guess you've mentioned it a couple of times, so it'd be really good to hear from you, Francis. I have some understanding, but I guess it is something I don't think that a lot of us are very much aware of. So who are polio survivors?
Yes, I think we're a bit of a hidden community. But most people have heard of polio as being somewhere else. Very good publicity, and it's great work being done by the eradication program around the world. When the Polio Fellowship started, the cases of polio, though, in the UK were annually running at about 300 to 1,000 per year. It varied, it was seasonal. If you had an outbreak at one year, you probably didn't have an outbreak the next. So it went up and down quite a bit. But from about 1947, the number of notifications of polio rose dramatically. At its peak in about 1950, it was about 7,000 to 8,000 per year. And the last biggish blip, if you like, was in 1961. There was nearly 1,000 notifications. So most people in the United Kingdom who are living with the after effects of polio are certainly over 50. Over that whole epidemic period, there was something like 50,000 notifications of what's called paralytic polio. And that is what polio does, and we're so delighted that it's the Neurology Academy that we're talking to today. is it attacks the nervous system. And I think that is one of the key areas that isn't widely known by the current professionals, because in the West, the success of the vaccines started to be distributed widely from about 1956 to 57, brought down the cases of polio to extremely low levels across the world. But it's been a slow journey. So polio attacks the nervous system, particularly the motor neurons, and that then affects the muscles. When you see a polio survivor, most people think, oh, you've got a muscle disease, because I can see that you've lost a lot of muscles, particularly on your legs. And it's also an enterovirus, so it enters in the stomach, in the fecal oral route, and it likes to live there because that's the type of virus it is. And in a very small number of infections, it gets into the bloodstream, and from there, in an even smaller number, it gets into the nervous system. And that's where it does the damage. As a stomach infection, it's not too bad. It can go unnoticed, a bit like flu. But once it gets into the nervous system, it can cause paralysis almost anywhere in the body. And most images that you will see around polio are of iron lungs. That was the cause of death at the time, before a lot of the respiratory management techniques were developed. And basically, if it gets to the breathing muscles or the bulbar system, the swallowing, it can cause really immediate life endangering condition. But what it does for most people is it kills off a lot of the motor neurons and therefore causes weakness. Typically, a polio survivor will have had a very acute infection, be left with a residual, the long-term effects of polio, mostly in the legs, very weakened muscles. Because the muscles are weakened, then you also get skeletal problems, so you get quite a lot of scoliosis, and that in itself can also affect breathing. And people have lived with those. If we're talking about the people in the United Kingdom, people have lived with those effects, the long-term effects of polio, for many decades. They will have been discharged from orthopedic care at 18, and after that there's been nothing. There's been nothing specific for polio for the rest of those decades. And the culture of the time, and it worked to an extent, we were pushed to learn how to walk again. That was the target in the 1950s, to be recovered from disability, to not be disabled. And so you find that most polio survivors have been pushing themselves extremely hard with a weakened neurological system to do as much as they absolutely can, working at the peak of what they can do. But what we find also is that if you're living with those sort of muscle losses, you put a lot of strain on joints, on different parts of your body. One part of your body will be working harder than another. And it can cause all sorts of things like joint problems. You can get osteoporosis is more common in polio survivors than the typical population, because you can't do as much when you were young and building bones. You can get breathing problems that develop because of the scoliosis. These are the late effects of polio due to having lived with a physical disability, an extensive physical disability for decades. But what also happens is part of the recovery from the initial paralysis involved motor neurons, what's called re-innervating bits of muscle where that neuron died. And basically, some motor units are working extremely hard, and they start to fail. You start to get new neurological weakness, new muscle atrophy, sometimes in places that didn't look to be affected by the original infection at all, and that's post-polio syndrome. So to sort of summarize, there are likely to be tens of thousands, almost certainly many tens of thousands of polio survivors in the UK today who've been living with a range of disabilities. These people will be ranging from permanently in wheelchairs to people who can mostly walk and maybe not even be considered to be visibly affected. And they will have a huge range of problems, possibly with sleep, fatigue, pain, falls and fractures. I mean, you ask any polio survivor about falling, it's a very common activity. But they're a very tough community as well, and find it hard to make changes, I'd say. Find it hard to admit to weakness. That would be, in a nutshell, what I think about the polio survivors.
Yeah. Well, thank you, Francis. It's really complex, huge amounts of symptoms. And as you say, I think probably very much a lack of awareness. I definitely speak for myself with that. And some of what you're saying is resonating across some of the other long-term neurological diseases, maybe slightly more advanced with what support is available. What would you say is the biggest, I mean, you have mentioned some of this already with the kind of issues with engagement as the polio survivors try and engage with adult services. What would you say is the biggest problem that they are facing at the moment?
I previously worked at the Lane Fox Respiratory Service as a specialist in rehabilitation medicine, and I must have done around 3,000 or 4,000 consultations with polio patients over the past 6 years, seeing a whole array of physical disability, some with respiratory problems, to chronic pain, to weakness and fatigue. And it was quite a privilege, really, to come alongside each of these patients and listen to their stories. And subsequent to these 6 years, I was involved as a clinical lead to develop the pathway for polio survivors. From a neurological perspective, post-polio syndrome is not always accepted as a diagnosis. And don't forget, this is a clinical diagnosis. It's not something that you find on a nerve conduction study. The best I ever found on a nerve conduction study was signs of old polio. But what's very interesting clinically is that when you look at this cohort, more than 50% do suffer from functional deterioration that occurs, some 15, 20 years or more after the initial infection. And you can really see the suffering and the physical disability that patients suffer from, and often have had quite adverse psychological experiences early on in life.
I would say the biggest problem is a lack of awareness and a lack of understanding. I started off by saying that we are a bit invisible as far as polio isn't taught about in the Western world in medical systems and medical training courses because it's considered extinct. So, and our numbers are not huge. We're talking about perhaps a GP seeing one person who's had polio in their life, or at least one person that he knows had polio in their life. We're talking about a condition that was a long time ago, so it's not necessarily on a record. It's not necessarily something that's passed. If somebody's referred on from, say, GP to a consultant, their background in polio isn't necessarily passed on. So awareness that it's here, that somebody sitting in front of you can have been a polio survivor, particularly if they're over 50. And also the understanding, I think I mentioned that it is a neurological condition at its root, and that isn't understood. Our members tell us that people don't actually understand the involvement of neurology and neurological rehabilitation in polio survivors. It is quite rare, and quite needed.
But would you say it sounds like it's quite sort of multifactorial? So for polio survivors accessing good healthcare, is there part an issue that they don't know what care is available, so they're not necessarily accessing it? But then on the other side, we have general practitioners who may be, they have to have a small amount of skill about a lot of things, and maybe this is an area that there is more education around, but also there's education within neurology teams. So it sounds like it's right across the spectrum that, so people approaching, at for people with polio, trying to access care, but also from the other side, maybe there's not been in the past a very clear idea of what that should be, what that looks like. Would you say that has been
Yes,
the
I would agree.
experience?
It ranges right from the polio survivor themselves. Not going too far down this route, the NHS systems have been reformed. If we're looking back over a history of 60 years of living with this condition, the NHS has changed hugely. Even the disciplines that you see in the NHS has changed hugely. So most people in the early days will have had orthopedic care. That's where you went to after the acute infection hospital. But really these days, the orthopedic care is only one small part of the care that a polio survivor needs. And at the root, any person needs a holistic assessment of anything that might have been affected by polio. So their sleep, their breathing, their walking, their aids that they use, the social care support. And I think in our pathway we have listed the type of clinicians, healthcare professionals that are needed, and it's a very long list. It's speech and language therapy, it's respiratory therapy, it's psychological therapy, it's vocational occupational therapy, because people are still working. Not the majority of people in the UK got polio, but a significant number are still working. So yes, I agree, it's education across the board.
Would you say that everyone with polio was diagnosed at the time they had polio? Was there that level of knowledge? Or are there, you talk about there being thousands of people, or a large number of people with polio, and obviously the fellowship are supporting. I'm wondering if there's issues where patients are presenting, but that background isn't known.
Yes, that's absolutely true. It's a little bit, it has parallels with COVID. If you had 100 people infected with the polio infection, just, through the gut, maybe between 4 and 8 of those would develop a quite visible infection and fever, and maybe one of those would have visible paralysis, and maybe one would have quite a significant effect and be classified as non-paralytic polio. In England and Wales, there were about 50,000 notifications of paralytic polio. There were only 17,000 of what was classified at the time as non-paralytic polio. But the general consensus is that the ratio between those two is about 1 to 1. So there's a lot of people not notified. And if you read the reports at the time, you see many reasons for this. In an infant, it's very hard to tell if they're weakened. But also, if you're mildly affected, there are case histories of people who started to had a slight weakness of the leg after what they felt was flu or something, and just managed with it. And they probably would never have appeared on a notification. There was also a social stigma, because in the years of the epidemic, people got very afraid about catching polio, especially because while it did affect children mostly under the age of 4, it did affect a significant number of adults as well. And sometimes the impact on them was even harder. So there was a stigma as well, and we have members who were never told they had polio by their parents. Maybe their parents were told, but they weren't, not until a lot later. There were people who thought it was just a mild infection and a bit of weakness afterwards. So those numbers, we don't know. Could be very large indeed, could be hundreds of thousands.
Yeah.
I just add to that and say that it's also, there's a good chance that if there's more than one child in a family, then the siblings would have had it in a much more mild way. But obviously the parents were focused on the one who was experiencing polio in a much more acute way. So as a result, the siblings who had it were written off as just a mild flu type thing. So there's a good chance again. How do you tell? Lots of guesswork.
Yeah. Yeah, and I mean, before we go on to, there's obviously a very clear reason why you put together this optimal clinical pathway for polio. But before we go into that, I wondered there may be people that are listening to this that have questions or concerns, or it's bringing up things that they just want answers to. Where would you recommend that they they go to speak to yourselves and maybe their general practitioner, or do you have any other thoughts?
Emma, if I'm answering that, I would say that the Polio Fellowship has been the main place in the United Kingdom for providing information. It is a significant strand of the work that the BPF, that Kripen and his team do. And we have a lot of documents and fact sheets. But I would also encourage anybody who's got any concern to please go to their GP, to please say, you may not be sure, you may have a notion, but please go, because that is ultimately where you will get some treatment, some help with managing the condition.
Yeah, thanks, Francis. Do you want to add to that, Kripen?
Yeah, so basically, I think it's a good idea to contact an organisation like the Fellowship to maybe basically understand it a little bit better before you go to the doctor to, what's happening and how it's linked to your prior polio. And we can provide that information. But, and then absolutely, I totally agree with Ross. Go to your GP, get the referrals that you need onwards. But also, the Fellowship as such offers a lot more than a direct information service. So we have the facilities such as the contact with other polio survivors, which you may not have had in the past. Access to events and information events. Access to grants, which may help you. And also being the voice for the polio community. So being counted as part of the polio community, not just for your own sake, but for all those people who may not know they need help to get.
Yeah, thanks, Kripen. I think that's really key information. And I don't think I need to ask why you chose to develop this pathway. I guess what would be really useful to know is who was involved in this and what you were kind of hoping to achieve with the optimal pathway.
So what we did with the pathway was we got together medical professionals, but we also had a patient group really trying to draw together the expertise on various areas, not just from a medical perspective, but nursing, therapy, orthotics. And often these patients will have quite complex orthotics, pain needs. Sometimes they need the respiratory physician for non-invasive ventilation. And the pathway really tells that story, listening to our patients. And so the important bits of the pathway are that patients have a referral from their GP and are referred to a specialist centre like the Lane Fox Respiratory Service to have a good diagnosis. But really it's about identifying patients' needs, their impairments, functional barriers and things that we need to manage and develop a really good care plan. And that care plan can be developed more locally. And that specialist assessment is really an MDT, one of that is MDT, and really co-partnering with patients and help educating them, empowering them in their lifelong care and to be able to navigate the health system. Often patients will see their GP or have seen the neurologist and had a diagnosis, but they feel adrift sometimes that they don't get the practical help and also the way of managing their disability. Often these patients have severe fatigue, new weakness, they might have struggle walking, difficulty living in their home environment, and may have to use a wheelchair. Some are very severely disabled from birth and may develop more respiratory problems. So that's really what the pathway is trying to address. It's clearly stating what the pathway is, standards of care, and how specialist services should run. And we're really trying to empower the patient to be able to, travel along this pathway.
one of our key partners is the Neurological Alliance, and we work with all neurological alliances across the UK. And I was hearing a lot about pathways and how they help other neurological conditions, patients manage their condition and care. I've been with the fellowship 10 years this October, and throughout my fellowship journey, I've been hearing about the barriers that polio survivors face in terms of getting the right care at the right time. And the fact that if they do get the care in the right time, in the right way, it slows down the progression of the condition, leading to a better quality of life. So I started talking to key people at BPF at that time to say, other conditions are producing these pathways. It seems like NHS systems understand pathways and are adopting them. So should we consider doing one specific for polio survivors? So then we started quite a long process of finding out what needs to be done to produce a pathway and who needs to be involved. And the Neurological Alliance specifically in England was very helpful in terms of guiding us through that process and understanding what should happen. But we spent a lot of time getting the right clinicians in our steering group to ensure that the pathway was informed by clinicians who would be working with polio survivors, even if possibly the clinicians didn't know that themselves at that moment in time. But the other aspect of this is at the heart of this document was the polio survivor and the polio community. And so we also spent a bit of time getting a patient experience group together to hear the patient voices from all sides of the polio community, because without that, the document would not be as strong as it could be. So we spent a bit of time ensuring that we followed a good process. So we had meetings with the steering group and the patient experience group. We appointed Simon Shaw as a lead clinician for this project. We also contacted organisations like the ABN and the RCGP and the Royal College of Nursing to see what they think needs to be in this document as well. So we spent a lot of time consulting with clinicians and the polio community, and then we went through and produced the final document. So it was quite a long and detailed process, but I think it was worth doing to ensure that the document had the gravitas that it needed to be adopted.
Yeah, thanks, Kripen. Francis, I don't know if you want to add anything, especially around like how it's been since the launch of the pathway and what you're really wanting the key changes to be, I guess, in the NHS and improving experience.
Well, I think one key change, would be if the people, and I was just encouraging to go to their GP, that GP actually knew where to refer them to. And this is not clear. I mean, everyone is aware we've got these integrated care system has been introduced, and basically it is now the place that commissions facilities. It isn't easy in any area to find out where the expertise actually is. And I'd like that to be much clearer. We spent a lot of time getting quite a wide range of the relevant specialisms involved, so respiratory, physiotherapy, occupational therapy. I would like to see that polio is visible in their literature of the professional organisations. We have sent the pathway to the integrated care boards, and we're getting quite some response, some good, quite varied, but nowhere near as much as we actually need as yet. It's a slow process. Basically, it's awareness and understanding, and it to be included in some of the educational material that is produced by the various organisations, including yourself, which we're absolutely delighted to be here today.
Yeah, thank you. So I guess, who would you say the target? I'm just thinking it's multidiscipline, isn't it, really? It's partly to, I guess the key focus is to help educate and support people with polio, but also then to reach out to the clinicians across primary, secondary care. Is there key clinicians that you find that people with polio tend to be presenting to, that you really want to be upskilled in this area?
Well, the absolute basis are the general practitioners, for them to be able to recognize that something is due to polio or is sufficiently concerning that maybe it needs to have a wider assessment to make sure there's nothing else. So the GPs are quite key. The discipline of rehabilitation, I think, is probably the best area to tackle. This can be either the neurorehabilitation or community-based rehabilitation. We have quite a range of people. So we have people who are quite severely affected and have quite complex conditions. And we have people who are more mildly affected, but their quality of life could be greatly enhanced if they had the correct assessment, if they had the correct orthotics. Orthotics is something that polio survivors have struggled with over the last few decades because we've lost a lot of expertise in the certain areas. Prosthetics, has gone on through vast changes and vastly improved, but the type of things that we wear, there's a lot of skill lost there, I think, a lot of understanding. But again, key to getting that delivered is the person who coordinates the care and gets the right thing at the right time. And that, I think, is the rehabilitation consultant. There are so many disciplines that are important, but also physiotherapy, because we have a lot of injuries, so strain. We need to know how to use our orthotics, how to walk with them properly to make sure we've got the right one. So they are very key as well. And I think there are challenges currently in the NHS where some disciplines are, and I can understand it for efficiency reasons, some disciplines are siloed a bit. So you'll get somebody who's a specialist in knees or somebody's a specialist in hips. But if somebody has a problem, polio survivors a problem with their knee, it could be their orthotic, it could be their foot, it could be their hip, it could be their back. It's not the same as somebody's just fallen and twisted their knee. So I think the pathway includes calling for a care plan, which to provide better communication across the disciplines, but also somebody who is the key coordinator for that person of care. For somebody who's more mildly affected, that could easily be a GP. For somebody who is more severely affected, that is more likely to be a rehabilitation consultant. It could also be an experienced physiotherapist in the sort of middle ground. It is so wide-ranging, it's hard to pick one.
Yeah. No, absolutely. Yeah, thank you for that, Francis. And to anyone listening, please have a look at the Optimal Care Pathway on the British Polio Fellowship website. They have, as you've already mentioned, Francis and Kripen, a huge amount of information and fact sheets. And just please share this with your colleagues. Talk about this. I think starting the conversation and acknowledging that is something that we don't know so much about is key, and this optimal care pathway is definitely starting the conversation, which is really important. I don't know, in closing, Francis and Kripen, if you have anything you would like to add.
Can I just add something about the team, the MDT team? And I think really one thing that often gets overlooked is the mental health aspect of it and looking at people holistically. And I think often that particular polio survivor is one of the biggest barriers in getting the care they want or need. I think that's really, really important that they get that support either locally or through the polio services that they use. But my main call out to people would be to help us reach the polio community, really, because we know there's many people out there still not engaging with us as an organisation or going to get help for their polio either because they're not linking what's going on with them now to their prior polio, or other social or other cultural reasons why they may not be doing so. So I really urge everybody to help us engage further with the polio community in any way they can, either by signposting to us or raising aware of polio matters or the work the BPF does.
That's right. Thanks, Kripen. Francis?
Yes, I would certainly agree with what Kripen says about the psychological aspects, because we're talking about people who contracted a very painful, distressing disease as an infant, were in hospital for many years without family. At the time, the conditions were of the needs of children were not given the importance that they are now, and then pushed really, really hard for much of their lives. And I think that gives a certain sort of experience that's hard to deal with sometimes. In closing, I think I would say we are still here. You know, I'm 68 years old. I intend to be here for some time, and I know that, like many people, many of our members, we're in a phase where we are starting to have significant comorbidities and increasing frailty much earlier than we should, really. I think, please remember we're still here. Please also remember polio is not gone. People will be contracting polio today across the world, and humans are a mobile species. There will still be polio survivors in the UK after I'm long gone, though hopefully in much lower numbers. So basically, we're still here, it's still needed. And thank you so much for taking the interest in this today. We very much appreciate it.
Yeah, no, thank you, Francis. Thank you for that. I think what you've just said is really key, that we need to be aware that it's still happening today. I think the optimal care pathway, as we've already mentioned, is absolutely crucial to hopefully affecting the kind of breaking down the barriers, as you said, Kripen, improving care, improving awareness, and providing the education that's relevant to the different people that are involved, the different stakeholders, and supporting people with what you've described as incredibly complex symptoms, and helping them to access care. And so if you've been listening and you have any questions, please send them in. We can pass them on. And if there's anything that's been raised that you're concerned about, as we mentioned earlier, please get in touch with the British Polio Fellowship. I just want to say a really big thank you to our speakers today, and thank you for listening. And yeah, we look forward to speaking again soon. Thanks.